when's the last time you did a total spinal with local anesthetic for your spinal cord stimulator? I haven't seen that happen ever.
Did you just answer with a question?
Yeah. Socrates, man. This is how Socrates does it.
He's like, I want an answer. All right. Welcome back to the OuchCast. Today, I have two very special guests. I have Dr. Hemant Gulati, interventional cancer pain physician in New York and the current president of WAPMU. And then I have another special guest, Dr. Hemant Kalia, who is an interventional pain and cancer rehab physician who successfully started a cancer pain rehabilitation program at Rochester Regional Health System. I didn't miss anything, right?
No.
Okay, good.
We got it.
I said it like 5 times.
A lot of words there.
There were a lot of words, but I think I got everything. And we are going to remove this.
All over again.
Is this? Yeah. All right. Well, we might as well just keep that at this point.
That was cool. I like that. It was like a makeup kit. I was kind of cool about that. I liked it. Kind of blended me in.
Today we're going to be talking about neuromodulation in cancer pain. And you guys are pretty uniquely fitted for this topic because it's not something that everyone really does, and there's a lot of intricacies into it. So let's start off with the simple thing.
What it means.
Yeah, what is neuromodulation?
Yeah, well, first of all, thank you for having me. It's an honor to be on this podcast and share the stage with Dr. Gulati. So neuromodulation, I always go back to the definition of neuromodulation, which was given to us by Dr. Robert Levy, who's the editor-in-chief of Neuromodulation. Basically, what he defined neuromodulation was not only limited to delivering stimulation in the peripheral or central nervous system, but also delivering pharmaceutical agents in the central nervous system to optimize the management of pain. So that range gives us, starting from deep brain stimulation to spinal cord stimulation to peripheral nerve stimulation, and targeted drug delivery.
So there's a lot there, and all of that falls under the auspices of neuromodulation.
Correct. Even
the medications, which I think some people wouldn't conventionally think, but that is a whole kind of sect of a lot of what you do. What specifically is different? When we talk about these, obviously people are getting these not in the non-cancer world. What's specific about the cancer world that makes this a little bit more difficult?
We're trying to help a population that's really suffering. And they're suffering and they may not live a very long amount of time. So whatever treatment we choose, we want it to work quickly.
Yeah.
2,000 years ago, we might have put someone in a pail of water and put a bunch of eels in there. But now we can put a little wire in the spinal cord on a nerve and hope that we can use electricity to either confuse the brain so they don't feel pain. And you can imagine that for a cancer patient, the immediacy of that treatment is very powerful.
I would agree. I think there are two big themes or major aspects specific to cancer pain. One is the window of opportunity sometimes is very narrow. So you have to be on top of the timelines in which you can offer these treatments to the patients. And then cancer pain is complex.
Yeah.
Cancer pain is not as straightforward as your regular chronic pain.
Why is it complex? Why do you say that?
So there are a lot of different ways to look at it, right? So you can have pain directly because of the cancer itself. Mm-hmm. And then there are pain syndromes which are related to the treatments of the cancer, which can vary from your side effects to chemotherapy agents, radiation therapy, and slew of other things. So that makes cancer pain specifically a very challenging syndromic diagnosis. And you literally have to understand not only the pathophysiology behind the pain transduction and translation which is happening, but also understand the cancer treatments and its associated side effects and develop a neuromodulation plan for these patients.
What are obviously there's a lot of treatments and things that cancer patients are going to undergo. What are the things that give you pause? Like, is there specific chemotherapy things, or is there specific things that they're doing for these patients that say, hey, we can't do this now?
I mean, I think one of the unique things about cancer is while we have devices in pain medicine that are improving maybe every few years, we're seeing something new, novel idea. In oncology, the new treatments are coming in 6 months, 9 months, and they're causing different issues depending on what drug they're giving from a chemotherapeutic agent or immunotherapy or some variation of an antibody. In radiation, we're seeing much more precise distribution of radiation causing less neural injury around a tumor. So you see some very unique things happening in oncology that we have to be on top of. Even though it's very complex, what's really interesting about it, what we're dealing with these kind of patients is that we know where the problem is. And as long as we can interrupt that signal, we're not dealing as much with like chronic pain, mental health and those kind of things. We're really trying to deal with an organic pain problem, which helps us kind of focus our efforts a little bit as well.
Okay. And what about like the classic things like anticoagulation? Are there specific chemotherapy agents that change people's like platelets, for example? Is that considerations that you take into account?
Yeah, absolutely. I think that's exactly why it's a...
Yes.
No, we don't care about that.
We definitely care about that. Number one priority.
Yeah. And I think that's exactly why it's a team-based approach.
Yeah.
Right. So in cancer pain management, the idea and the concept of a true interdisciplinary model of care is really, really, really important.
Right.
Not multidisciplinary, but an interdisciplinary model of care where the goal of every single specialist is the same. And if you're anticipating any regional blocks to advanced therapies like spinal cord stimulation, peripheral nerve stimulation, or an implantation of a pump, that decision needs to be taken in conjunction with the team, which is your oncologist, your radiation oncologist, and your palliative care physicians as well.
Yeah, you bring up a good point. I think you have to know all the other doctors that are also managing pain, right? That's the hardest thing probably in oncologic medicine is that there's surgeons, there's rehabilitation physicians, there's palliative or supportive care physicians, there are radiologists, there's radiation oncologists. They're all trying to manage the pain in various forms. And you almost want to collaborate together to have a comprehensive plan. And then when those physicians know the things that you do, it may be that a radiation oncologist is asking you to implant a peripheral or spinal cord stimulator for a neuritis from a radiation, whereas they may not have known those choices before.
Yeah.
And so, where we are, a lot of discussions happen about some of these pain problems and have a comprehensive plan.
Yeah. So I'm getting the difference is like there's a lot of permission that is necessary before you're able to do some of these things because it's a multifactorial plan that these patients are undergoing.
I would not use the word permission here. It's
Define that word.
Yeah, sorry. It's like as a person.
I think it's from Latin. Per.
Yeah.
Yeah. It's more of a collaborative approach.
Yeah. All right. Fair enough. Point taken.
Yes. We should define OuchCast as well. Maybe the wrong word for that too.
Let's go into specific. Let's start kind of far off in the body. Let's do the peripheral nerve stimulation, where you're essentially stimulating some of these nerves that are further out, maybe towards the legs, the arms. What do you use these for? Do you use them at all in cancer?
Yeah, we use all types of neurostimulation, or I should say neuromodulation treatment options, which are available to us to manage pain.
Yeah.
And I don't look at it as individual therapies per se, right? So you have to kind of work backwards where you have to understand the pain syndrome. Mm-hmm. You have to understand where the pain is getting modulated, whether it's getting modulated at the peripheral level, whether it has centralized it into the DRG or spinal cord. What are the different sites where your treatment options or your neuromodulatory options can help manage the pain? And then you choose your appropriate neuromodulation therapy to improve outcomes.
Okay.
What I like about peripheral nerve stimulation, especially some of the newer devices, is that just like Hemant had said, we may not be as interested of what we're stimulating as more like where the location is. But what's important to us is we can probably put these peripheral nerve stimulators a little bit simpler than some of the spinal cord stimulator implants. We were talking about anticoagulation earlier. Some of the risk of placing a peripheral nerve stimulator may not be as significant as a spinal cord stimulator. We may have an opportunity to use these kind of novel devices and some oncologic pain states that otherwise patients may not get an option for because of the stimulation device being placed in the spine.
I agree. I think you bring in a really, really important point. And we have seen evolution of these devices in the last 5 to 7 years, where now we have some temporary devices available to be used under ultrasound guidance in about 20-minute procedure in and out, where you can mitigate all the risk factors which come with more advanced implantable devices. So even in the peripheral nerve stimulation paradigm, you have a lot of options to help these patients' pain.
Give me, like, before we delve into that, I want to know specifically what patients are you saying would benefit? Like, what do these patients have? What are they presenting with that you say that a peripheral nerve stimulator is particularly good for them?
A classic example would be if their pain is limited to 1 or 2 dermatomes, and if can be limited to one specific named nerve, then that's a home run.
Okay.
We've seen some good stuff, patients who had sarcomas in their leg, we'll place it to help them with their surgery, their post-surgical recovery. Had a couple of patients with active disease of the brachial plexus, like a Pancoast tumor. I think the idea of neuromodulation helping with pain electrically or chemically is not as important as someone may benefit just with feeling something different than pain.
Yeah.
And taking that idea and applying it both to treatment, like Hemant has said, treatment-related pain syndromes, radiation, maybe some injury from a chemotherapeutic agent on a nerve, but also active compression, surgery. There's a lot of opportunities, both with peripheral nerve stimulation and really spinal cord stimulation, which really traditionally has been used for cancer pain medicine. These newer devices are really doing some novel things. We can see some good applications that we hadn't thought of before.
Okay. So obviously we find one specific nerve or a dermatome. So someone says like it kind of shoots down like just a portion of my leg or even like the arm. So a Pancoast tumor, someone has pain that kind of goes along here. You're able to kind of capture that with a peripheral nerve stimulator. You talked about permanence versus temporaries. Is there a mentality about whether you choose one versus another? Is there something like what's the idea? How would I know whether I choose one versus another?
I wish we knew the answer to that question. What I will say is probably best now to know all the different options you have for patients.
Yeah.
And then give patients the option of choosing what's best for them. And we can give some experiences of temporary devices, permanent devices, and benefits and risk. And it may be things simple as you cannot get an MRI with a device and you need an MRI every 2 months. This is not an option.
Yeah.
But I think as we grow as a specialty, we just need to know every device that's available, the pros and cons of the device, and then put it in context of the patient would be most beneficial, because this is a very difficult decision right now in terms of which technology to choose for which pain problem. But on the other hand, it's fun for us. We get to, we have all these things that we could do, and we're using our experiences, our intellect, our mentors, our colleagues to say, what have you done for this situation? And we can apply that to our patients in some form or fashion.
I mean, it sounds like the Wild West.
He has probably gotten, I've called him so many times on all these challenging.
We're all looking for ideas.
Yeah.
But the great thing is we have a lot of potential to apply to a population that's actually in a cancer where their disease is being controlled, they're living longer.
Yeah.
There's a lot of things we can do now. We're thinking differently than we did 15 years ago when I started doing this stuff.
Makes sense. Let's go a little more central. Let's go closer to the spine. Let's talk about spinal cord stimulators. So now, what do you use these for? How is this different than peripheral nerve stimulation for these patients?
Yeah, it's a good question. I think
that's why you got it.
It's like I'm not answering this.
I think the way to kind of look at it is, especially because we don't have great evidence behind which specific device or which specific neurostimulation, spinal cord stimulation therapy to choose, it kind of boils down to a lot of different, patient selection criteria. The key is to kind of understand the pain. If it's more than 2 dermatomes, if it's more diffuse and it's neuropathic, it has a higher probability to respond if we do central stimulation of spinal cord as opposed to a peripheral nerve. So that's one kind of idea of looking at it. Then obviously the current devices which are available in the market, there are some nuances as far as the MRI compatibility is concerned. So again, going back to the concept of shared decision making, right? So having a conversation with the oncologist to understand what are the future MRI needs for these patients, and then choosing the right type of a device and offering those options to the patients, because then you can get really, granular into, whether you're not a rechargeable battery or a non-rechargeable battery, and those are like much more deeper conversations. But from a 36,000 feet, I think if patients have more diffuse pain patterns, then those patients tend to do better with dorsal column stimulation.
And when you're saying diffuse pain, does that mean like all over the body, or are you just saying lower extremities, upper extremities?
Yes. So that's again a good point. So obviously it's not designed to help with your head to toe pain, right? So it's primarily, we base our decision based on our understanding of spinal cord stimulation literature from chronic pain. We know that it works well for neuropathic pain conditions in extremities, right? So if you have pain in extremities, then the probability of that responding to spinal cord stimulation is high.
That's very unique, right? I mean, for our patients, in the chronic pain world, I think the majority of the issues are going to be related to the lower back, spinal fusions. But for us, we have chronic pain problems in every location. To study all these things in cancer patients is very difficult. But you had these very unique attributes of every one of these devices that you could take advantage of. And I think you brought up the MRI compatibility, which I think is important. I had never been a radiologist before, but now I have to read these PDF files to figure out how to actually get an MRI with your device, which is important. But more to the point, we have pain syndromes that are very unique just to oncology in different parts of the body, and to cleverly think about how we can use spinal cord stimulation for active disease or radiation neuritis or chemotherapy is kind of gives us pause, but also gives us an opportunity of something we have a new technology from chronic pain world to apply to a cancer pain world, where people are starting to suffer from the treatment related problems and active disease that's being controlled.
What are the things that are kind of classic for like the oncologic disease? Like why is it different when it comes from like the chronic pain world? I mean, obviously there's disease that goes to like the visceral organs. Is that?
I think part of the active disease patients, people who are like have tumors, is that we're used to in a chronic pain world where people have a certain pain problem that's not very changing. Mm-hmm. But in oncology, sometimes the pain changes. When I was a fellow, we would kind of try to use our stimulators and try to find the part of the leg to stimulate with correlating with the pain. Yeah. But you can imagine, you place the devices right there in the spinal cord. But you can imagine if someone had a leg problem and all of a sudden had a hip problem, then has a right knee problem, and going from left to right. Yeah. Then the stimulator, which was designed for one location, can't necessarily help with the other location. Yeah. But these newer devices, it may not matter as much some of the things we understand about the spinal cord. And that's where we can apply some of these new technologies to even oncologic patients, which even we thought would not be amenable to stimulation in general.
Do you think like chemotherapy-induced peripheral neuropathy, where people get these weird numbness, tingling in their fingertips, their toes, any benefit there? Like, is there anything that you guys have seen there?
Yeah, that's another interesting topic, primarily because of what's happening pathophysiologically in that specific population. Now, if you look at the evidence, there is very sparse evidence on use of neurostimulation in that specific diagnosis. But whatever evidence there is, I think it points towards the basic underlying mechanism. I think the chemotherapy-induced peripheral neuropathy is probably happening because of small fiber neuropathy, and then those specific patients tend to respond better to dorsal column stimulation. Recently there was a clinical trial which was published on use of high frequency stimulation with diabetic induced neuropathy. So
we're talking about like the 10K hertz like stimulation.
Correct. So there can be some extension of that specific understanding of high frequency stimulation on these patients who have peripheral neuropathy due to diabetes in that population.
I mean, it is similar in somewhat in their presentation. So it's not kind of like a leap to say that it may work for that as well.
Yeah, neuropathies are very different from each other.
Correct.
But there's a possibility that some of these neural waveforms, whether 10K hertz or some of the other devices that have their own proprietary waveforms that can help you with these pain problems. It seems like that might be a better solution than some of the older paresthesia ones where people were feeling some sensation that's interfering with their neuropathy, which doesn't seem to work as well. And so I think there's a lot of opportunity of these devices that have their different waveforms to apply to chemotherapy-induced peripheral neuropathy, radiation neuritis. But I think as we've done more of these things, we find that it's not as easy as we think. There's nuances to the disease state that doesn't always allow stimulation to be as effective as we'd hope, that follows some of the older data that we see in the literature.
Correct.
Yeah. So I mean, I've heard a lot about like their potentials to help patients. What are the ones where you look at it and you're like, definitely not. This is not the ideal patient for like stimulation particularly. Is there patients that you see and it's like absolutely not a patient that I would put this in? Or does everyone have the potential?
I mean, there's definitely going to be psychological criteria. There's going to be like, can they use the device correctly? There's anatomic reasons where you can or cannot implant a certain device in certain locations.
So like there's a tumor in the spine or something.
Yeah, tumor in the spine, the periphery. There's a degenerative disc. You
can't navigate around.
You can't navigate around. Sometimes you can't place these devices and test them appropriately. I think probably the biggest one in oncology is, can they actually use a device? And because I think patients that are suffering from cancer, pain is not their primary problem. They're just trying to get control of their pain, but they're trying to enjoy life. They're trying to go every day to their oncology treatments. They're trying to survive, and they're hoping you can do something simple to help with the pain. And if you give a device that requires constant reprogramming and changing, and then you got to come to a clinic and modify things, you almost want things to be a little bit simplified and hope it works, because we're trying to get our patients to not perseverate on the pain. We want them to focus on living. And I think it's very different than a chronic pain state where like pain is the primary problem. Here in our case, especially for active disease, we're just trying to get them along the way so they can get their treatments and live.
Correct.
It's a different mindset.
It is. I think we can probably extend the mindset of chronic pain management from a neuromodulation standpoint to cancer survivor population. That's a different population altogether, which is increasing at an exponential rate in the United States. So
because the treatments are getting better.
Correct.
Yes.
Correct.
That's good news. Good news for all of us.
Yes.
So that makes sense.
Do your cancer screening.
Yeah. I was telling my dad to get his colonoscopy. He's scared of the colonoscopy.
Breast, MRIs are becoming more commonplace for these screening potentials. So keep that in mind.
Yeah.
What I mean, obviously we've been through the gamut of when you would do this, and specifically also that collaborative approach, which I really liked, is that you're always talking to the oncologists, the surgeons. You're trying to figure out whether or not, obviously, the hard stops, anticoagulation or platelet requirements. Are there patients where you start saying stimulation is not really the option, and you start looking towards an intrathecal pump? Which is as you said in the beginning, we're delivering medications directly to it, which is a portion of neuromodulation. When do you look for that? Yeah,
so I would approach that question with a background that we have learned a lot about, intrathecal drug delivery, or what we call targeted drug delivery, over the last decade. Our understanding of CSF flow dynamics have changed our approach to targeted drug delivery as well. In cancer patients, I think we have anywhere from level 1 to level 2 evidence using intrathecal drug delivery devices to help these patients manage their pain. If you have a patient who is, or with the shared decision making that you can anticipate that this patient will have an extension of the disease, and you will be going after multiple targets, which will be hard to anticipate through neurostimulation paradigms, then it might be helpful to proceed with targeted drug delivery first. If there are predominantly nociceptive pain presentations, axial pains of the spine, then the probability of those pains responding to targeted drug delivery is theoretically and relatively higher than your neurostimulation options.
Our experience with pumps for cancer patients is vast relative to neurostimulation. I will say peripheral neurostimulation has allowed us to try something before someone gets a pump. Most patients might clump, pump, and stimulation as a surgery of the spine.
Yeah. And
then peripheral neurostimulation as something more tolerable from a implant perspective, surgical perspective. It's easier perhaps to do. And people might be willing to try those things before they get to a pump or stimulator in the spine.
So you're doing a trial to the trial.
It's just trialing all day long. You get your treatments, you get your trials. It's going to go along and along and along.
I have a question for you, Dr. Gulati. Yeah. So what's your take on the role of diagnostic nerve blocks in the algorithm of, finding your PNS target? Or
I like to tell people, when's the last time you did a total spinal with local anesthetic for your spinal cord stimulator? I haven't seen that happen ever.
Did you just answer with a question?
Yeah, Socrates, man. This is how Socrates does it.
He's like, I want an answer. Answer with a question.
So I know for me, a local anesthetic block, it's very different than stimulation and some of the newer stimulation patterns, unless you're actually trying to do a nodal blockade or block a conduction of a nerve. But you gain information from a local anesthetic block. Correct. You still gain the anatomy. You still gain the idea that if you get a negative, if the block doesn't work, you may be questioning what your pain problem is. But you also get an understanding of the patient in general. That you give them confidence because you can take a pain problem away temporarily. They trust you. Yeah. We trust what you're doing. And so there's a little bit of those things. Can they handle a peripheral nerve stimulator procedure with or without anesthesia? So there's this value of doing a block. It may not correlate directly into efficacy of a peripheral nerve stimulator or a spinal cord stimulator, but there's a lot of secondary value to doing it. So I think all of us tend to do a block for various reasons, and I think you gather that kind of information and put it all together to give a package of how you're going to treat afterwards.
The reason I asked this question was I wanted to do a plug for if there are residents and fellows listening to this podcast.
Oh, we love shameless plugs here.
All of you should be listening and send it to everybody else. OuchCast.com.
Please get the interventional.
I don't think we do.
Please get the interventional algorithmic book by Dr. Gulati. There is a nice algorithm on how to approach a cancer patient as far as neuromodulation therapies are concerned. So my question, the reason I asked this question was to kind of understand your pathway and algorithm, how you go into PNS, SCS, and the TDD.
Yeah, I mean, for our first peripheral nerve stimulation is kind of going into, we used to do local anesthetic blocks with steroids, and then that wasn't effective. We would neuralize. I think Dr. Rakesh and Neal is kind of young and haven't seen all the neuralics we used to do 10, 15 years ago. And we've done significantly less of those.
Yeah.
That's some opportunity we've had at our institution. This is not globally applicable, obviously. But if you had those opportunities, we've seen a reduction of neurolytics in our presence because of electrical stimulation, because substantially probably.
Yeah, I've heard people used to do like tap blocks blind. That seems crazy to me.
I can do this podcast. I can do it blind right now. I'm blind.
We covered a lot. Obviously, we kind of got a sense of that there's a lot of options: peripheral nerve stimulation, spinal cord stimulation, and kind of an idea of what the patients that it can be helpful for. I feel like we could go in hours talking about intrathecal pumps. First episode was on intrathecal drug delivery, but we're probably going to talk more specifically about cancer patients. So that's another episode. Is there anything that I missed? Anything that any dying things?
It's pretty good. It's been fun.
I forgot to do the plugs. This show is brought to you by the World Academy of Pain Medicine United, WAPMU, and the educational support is provided by Medtronic. So thank you, everyone, and thank you very much.
And SPR.
For showing up on the podcast.
Thank you. It was a pleasure.